It is 2 a.m., and a massive water main has just ruptured above a hospital's primary electrical grid. Within minutes, the rising water threatens the backup generators. Ventilators in the intensive care unit have a strictly limited battery life, and local first responders are blocked by the severe storm that caused the break in the first place. If a physical server crashes during a corporate crisis, the immediate loss is measured in data and revenue. Here, the immediate currency lost is human lives. But the surging water is only the catalyst. The actual threat capable of destroying this facility is the absence of a coordinated leadership response to prioritize actions. Left to their instincts, highly trained professionals will try to solve the isolated problem directly in front of them. The maintenance crew might sprint to cut the main power to prevent an electrical fire, directly severing the exact lifeline the critical care nurses are fighting to maintain. Meanwhile, administrators waste precious time manually calling down department lists to track available beds or attempting to convene standard status update meetings while the building actively floods. This is operational collapse. It occurs the exact moment cross-departmental communication dies and individual units start hoarding limited resources, like flashlights or oxygen tanks, for their own patients. Panic and self-preservation actively accelerate a complex disaster. Surviving one requires a rigid, pre-planned structural override that completely replaces standard operating procedures. That structural override is the Healthcare Incident Command System, or HICS. It is an objective-based blueprint adapted from emergency services, heavily refined after the September 11th attacks, when regional communication networks collapsed and hospitals required a reliable method to manage catastrophic surges. This radar image tracks a hurricane approaching the coastline. HICS does not wait for physical destruction to activate. During a Level 1 activation, the system quietly monitors the external threat in the background, well before a single drop of rain hits the facility. When a severe crisis hits, HICS actively strips away everyday hospital titles. The chief of surgery or the head of maintenance lose their standard daily authority, and everyone locks into a temporary hierarchy designed for one specific mission. The structure is built on 5 core functions. The incident commander sets the high-level goals. Operations executes the physical work, planning tracks the timeline, logistics secures the necessary supplies, and finance tracks the costs to bypass red tape. Information flows strictly up the chain, and decisions flow strictly down. Instead of 200 people trying to fix a hospital at once, a rigid chain of command compartmentalizes the chaos, breaking a massive catastrophe down into manageable tasks. Let's rewind that 2 a.m. flood. But this time, the hospital declares a Level 4 activation, the highest tier of response, opening a dedicated command center. The incident commander steps completely away from the physical work. They do not pick up a wrench or a radio. Instead, they set 2 clear strategic objectives: keep the ICU running and isolate the flooded zone. With the goals set, the operations section develops highly tailored tactical plans. They dispatch a localized team to shut off the water valves exclusively on the 3rd floor, preserving pressure for the rest of the building. Simultaneously, logistics identifies a critical shortage of power, and finance immediately approves the emergency purchase of external backup generators, completely bypassing standard corporate procurement delays. The disaster remains identical, but the response is entirely mechanical. HICS replaces the confusion of isolated individuals with the coordinated movement of a unified machine capable of outmaneuvering an active crisis. These protocols rely on a structural engine that scales far beyond the hospital floor, a deliberate cyclical process known as the planning P. The vertical stem of the P represents the initial response phase where leaders establish command. The system then enters a continuous loop of management by objective. The incident commander defines overarching goals and allows section chiefs to brainstorm the exact tactics required. This structure creates a hard distinction between high-level strategy and technical execution. Leaders dictate exactly what needs to happen at a macro level, while trusting their structured team to figure out how. To prevent leaders from becoming overwhelmed, the framework enforces a strict span of control. This rule mandates that no single leader manages more than 3 to 7 subordinates, allowing the system to scale from a single supervisor to dozens of active responders. If a mass casualty event suddenly triples the number of incoming patients, the internal hierarchy absorbs the shock. It simply expands outwards, adding new layers of specialized subcommanders to manage the extreme logistical load without breaking the chain of command. And when a specific tactic inevitably fails, or resources run dry, subordinates do not go rogue. They push the problem straight back up the chain, forcing the incident commander to adjust the master objective for the next operational cycle. Disasters and critical failures are a guarantee in any complex operation. Total chaos is a choice. Whether managing a flooding hospital or a collapsing corporate supply chain, HICS provides a universal structural blueprint for maintaining rational leadership when the world falls apart.